Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 145 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, VCT, a 58-year-old, 140 kg male patient will have an elective CABG surgery, with aortic valve bioprosthetic replacement. He has a past medical history significant for type 2 diabetes mellitus and hypertension. He has no known drug or food allergies. He has a calculated creatinine clearance of 90 ml per minute per 1.73 meters squared. He will be admitted to the SICU post-op after the surgery with 2 chest tubes placed for drainage. So my question to you is, which of the antimicrobials listed below would be the most appropriate antimicrobial prophylactic regimen for VCT? Would it be A. Cefazolin 2 grams once within 1 hour before surgery, redosed if surgery lasts more than 4 hours, and continued for 48 hours after surgery, or B. Cefazolin 3 grams once within 1 hour before incision, redosed if surgery lasts more than 4 hours, and continued for 48 hours after surgery, or C. Vancomycin 2 grams once within 2 hours before incision and administered every 12 hours until 48 hours after surgery, or would it be D. Cefazolin 2 grams once within 2 hours before incision and administered every 8 hours until chest tubes are removed? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Cefazolin 3 grams once within 1 hour before incision, redosed if surgery lasts more than 4 hours, and continued for 48 hours after surgery. The prophylactic regimen for a patient without a beta-lactam allergy who is undergoing cardiac surgery should be a cephalosporin administered within 60 minutes of incision time, administered every 4 hours during surgery, and continued for no more than 48 hours. In this case, the patient has obesity disorder and weighs more than 120 kilograms, hence he should receive an initial dose of cefazolin 3 grams. That makes answer C correct. Given the patient's weight, administering cefazolin 2 grams initially is inappropriate. That makes answers A and D incorrect. Vancomycin is usually reserved for patients with beta-lactam allergy. That makes answer C incorrect. And the next question reads, which of the statements listed below best describes antimicrobial stewardship in the ICU setting? Is it A. Antimicrobial stewardship should not be instituted in critically ill patients because restriction of antimicrobial choices may worsen outcomes, or B. Daily clinical activities of a critical care pharmacist may constitute an antimicrobial stewardship effort, or C. The main goal of antimicrobial stewardship efforts is to decrease antimicrobial expenditures, or is it D. Formal antimicrobial stewardship team membership should be reserved for clinical pharmacists with infectious diseases training? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Daily clinical activities of a critical care pharmacist may constitute an antimicrobial stewardship effort. Although critical care pharmacists may not be officially part of many antimicrobial stewardship teams, many of the daily clinical activities constitute antimicrobial stewardship activities. These may include selecting the most appropriate treatment regimen and advocating the early de-escalation of antimicrobials. Even in the presence of a formalized antimicrobial stewardship team, these activities are often complementary to the formalized activities of the team. That makes answer B correct. Given the wide variations in clinical practice, it may not be feasible to include an infectious diseases trained pharmacist with every stewardship team. In that case, the activities and involvement of a critical care pharmacist may be even more crucial. That makes answer D incorrect. The goal of an antimicrobial stewardship team is to optimize therapy through selecting the most appropriate therapy that would minimize adverse effects and unwanted selection of resistant or opportunistic infections. Although decreases in antimicrobial expenditures commonly occur, this is not the main goal of the team. That makes answer C incorrect. Studies have shown that antimicrobial stewardship efforts in critically ill patients do not worsen outcomes. Given the aggressive empiric antimicrobial regimens commonly used in critically ill patients, antimicrobial stewardship should be instituted to minimize adverse effects and the emergence of resistance. That makes answer A incorrect. Let's move to the next question, please. And the next question reads, PCO, a 35-year-old female patient presents to your accident and emergency department with a past medical history significant for hydrocephalus since early childhood requiring placement of an internal CSF shunt. She presents with the following signs and symptoms: a body temperature of 39.3 degrees Celsius, an altered mental status, a WBC of 19 × 10⁻³ cells per millimeter cubed. Her CT scan shows no cause for concern about brain shift. A lumbar puncture is performed. The initial cell count shows elevated CSF white blood cells with a high proportion of neutrophils and low glucose. Neurosurgery is consulted for a presumed CSF shunt infection. So my question to you is, which of the empiric system antibiotic regimens listed below would be the most appropriate in this clinical scenario? Would it be A. vancomycin plus cefepime, or B. tobramycin plus piperacillin, tazobactam, or C. vancomycin plus ceftriaxone, or would it be D. ampicillin plus ceftriaxone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. vancomycin plus cefepime. This patient presents with a healthcare-associated CNS infection, given the post-neurosurgical and device-related etiology of the infection. The most common pathogens include MRSA and multidrug-resistant gram-negative organisms. In addition to neurosurgical management of the device, e.g., removal or revision, empiric antibiotic therapy is indicated, including therapy with agents having empiric activity against suspected pathogens and able to safely achieve relevant CSF concentrations. Cefepime and vancomycin are the most appropriate options listed with consideration of CNS-specific dosing. That makes answer A correct. Ceftriaxone does not cover nosocomial-acquired gram-negatives such as Pseudomonas. That makes answers D and C incorrect. Piperacillin, tazobactam would be reasonable according to the spectrum of antibacterial activity. However, poor CNS penetration of tazobactam limits the utility of this agent for meningitis and other CNS infections. That makes answer B incorrect. Let's move to the next question, please. And the next question reads, FKL, a 77-year-old male patient presents to your accident and emergency department in septic shock. Shortly afterwards he is admitted to your medical intensive care unit, where he is fluid resuscitated, after which he receives broad-spectrum antibiotics with piperacillin, tazobactam and vancomycin. After 48 hours of antimicrobial therapy, FKL remains hemodynamically unstable, requiring norepinephrine. His blood culture is positive, according to the institution's microbiology laboratory, which recently implemented rapid diagnostic tests using nanoparticle microarray technology, and the microarray results show the presence of Escherichia coli with the CTXM resistance gene. So my question to you is, which of the interventions listed below regarding the patient's antimicrobial therapy would be the most appropriate in FKL's clinical scenario? Would it be A. Change piperacillin, tazobactam to meropenem, or B. Add levofloxacin to his current regimen, or C. Add tobramycin to the current regimen, or would it be D. Change piperacillin, tazobactam to cefepime? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Change piperacillin, tazobactam to meropenem. The presence of the CTXM gene detected on Escherichia coli by rapid diagnostic testing usually signifies the presence of extended-spectrum beta-lactamase (ESBL). This may be why FKL hasn't yet responded to piperacillin, tazobactam. The most appropriate action at this point is to broaden the coverage to cover for potential ESBL-producing Escherichia coli. Carbapenems remain the drugs of choice for ESBL-producing organisms, particularly in patients who are hemodynamically unstable. That makes answer A correct. ESBLs are usually encoded on genes that carry resistance against other classes of antimicrobials, hence resistance to other antimicrobials is common, therefore adding either aminoglycosides or fluoroquinolones may not be appropriate. That makes answers B and C incorrect. Although at times ESBLs may be covered by cefepime, it must be determined by final AST. That makes answer D incorrect. Let's move to the next question, please. And the next question reads, LJL, an 83-year-old male patient who presented to your accident and emergency department is admitted to your medical intensive care unit, due to a presumed line-associated sepsis. His blood culture grows a pan-sensitive Enterobacter cloacae. The patient is being treated with IV ceftriaxone, and the offending central venous catheter is removed. LJL initially responds, but on day 10 of therapy, he becomes febrile, and blood cultures are resent. At that time, the patient was maintained on ceftriaxone because he was hemodynamically stable. Gram stain for the new blood cultures is positive for lactose-positive gram-negative bacilli. So my question to you is, which of the strategies suggested below would be the most appropriate course of action for LJL's antimicrobial management now? Would it be A. Continue ceftriaxone alone, or B. Switch from ceftriaxone to meropenem, or C. Switch from ceftriaxone to piperacillin, tazobactam, or would it be D. Switch from ceftriaxone to ceftazidime? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Switch from ceftriaxone to meropenem. Enterobacter cloaca are AMP-C beta-lactamase producing Enterobacteriaceae. The use of ceftriaxone or extended-spectrum penicillins e.g. piperacillin, tazobactam or ticagrelin, clavulinate may select out depressed mutants, which are capable of causing the hyperproduction of AMP-C beta-lactamases. Derepressed mutants are capable of producing resistance against third-generation cephalosporins, monobactams, and extended-spectrum penicillins. In this case, the patient was taking 10 days of ceftriaxone before a new blood culture was growing lactose-positive gram-negative bacilli. Because lactose-positive gram-negative bacilli are usually Enterobacteriaceae, growing multi-drug-resistant pathogens such as Pseudomonas aeruginosa and Acinetobacter baumannii is less likely. Hence, the most likely resistance mechanism in this patient is either selection of derepressed mutants or acquisition of a pathogen with ESBL. Both of these resistance mechanisms are adequately treated by a carbapenem. Hence, changing to a carbapenem pending final sensitivities is the most reasonable option. That makes answer C correct. Both types of resistance mechanisms are capable of producing resistance against ceftazidime and piperacillin, tazobactam. That makes answers D and C incorrect. Because the patient developed a new bacteremia while taking ceftriaxone, it is not reasonable to continue ceftriaxone alone. That makes answer A incorrect. Let's move to the next question please. And the next question reads, ORM, an 82-year-old female patient is admitted to your hospital, with a past medical history of end-stage renal disease, ESRD. Her chief complaint is respiratory distress requiring intubation. She also requires fluid resuscitation and hemodynamic monitoring. Bronchoalveolar lavage cultures grow MRSA. ORM is being treated with IV vancomycin. On day 4 of therapy, ORM develops fever, leukocytosis, and erythema around the insertion site of her tunneled dialysis catheter. Blood cultures are sent, and the dialysis catheter is removed. Gram stain from the blood cultures is significant for positive cocci in pairs and chains. The medical team discontinues vancomycin and approaches you to inquire about treatment options for this patient. So, my question to you is, which of the antimicrobial agents listed below would be the most appropriate for ORM's treatment now? Would it be A. Tegacycline or B. Ceftaroline or C. Linezolid, or would it be D. Daptomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Linezolid. The patient is only on day 4 of therapy from proven MRSA pneumonia. However, the patient developed a bacteremia with gram-positive cocci in pairs and chains despite receiving systemic vancomycin therapy. The most likely culprit is a vancomycin-resistant Enterococcus species. The medical team has already discontinued vancomycin, therefore the new therapy must cover both the MRSA pneumonia and the possibility of a vancomycin-resistant Enterococcus species. Linezolid has good lung penetration and can adequately cover vancomycin-resistant Enterococci. That makes answer C correct. Daptomycin would provide adequate coverage for vancomycin-resistant Enterococci, but because it is inactivated by lung surfactants, it is not a good option for the treatment of MRSA pneumonia. That makes answer D incorrect. Ceftaroline covers MRSA and has good lung penetration, however it covers only vancomycin-resistant Enterococcus faecalis, not Enterococcus faecium. because, at this point, the speciation of the gram-positive cocci in pairs and chains is not available. Ceftaroline is not the best choice. That makes answer B incorrect. Tetracycline does cover MRSA and VRE, however, given its large volume of distribution and relatively low serum concentrations, it may not be the ideal choice for the treatment of bacteremia when other treatments are available. That makes answer A incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 146.